Hello all, and welcome to another edition of the Vertical Integration Program. So today we have a very relevant topic, that is cerebrovascular accidents, where we will be covering certain basic concepts in the management and the workup, and also the basic science perspectives in cerebrovascular accidents. For this, we have a very eminent panel. And introducing the panelists for the day, we have Dr. Supriya, who is an assistant professor in the Department of Anatomy, Dr. Lalitambika, Madam is an associate professor in the Department of Physiology, Dr. Rajashekar, faculty in the Department of Radiology, and Dr. Shankar, who is a faculty in the Department of General Medicine. We will be following the usual format with few pre-selected questions. And I'll start with Dr. Supriya. We can start the discussion with a quick overview of the overall circulation of brain. Yeah.
Okay, sir. Cerebrum is supplied by, that is CNS is supplied by two sets of circulation, that is anterior circulation and posterior. Okay, anterior circulation, it is formed by the mainly internal carotid artery, and posterior circulation comes from the vertebral artery. Okay. So internal carotid artery, it is one of the terminal branch of the common carotid artery. Yes. It is within the carotid sheath in the neck. It ascends upward and enters through carotid canal, then enters the middle cranial fossa through the foramen lacerum, then it traverses through the cavernous sinus, then pierces the dural roof of cavernous sinus, and ascends upward and backward and divides into two terminal branches, that is anterior cerebral artery and the middle cerebral artery.
Right.
Then coming to the this cerebral artery, anterior cerebral artery, it runs within the median longitudinal fissure of the brain, and the two anterior cerebral artery are interconnected with each other by the anterior communicating artery. Then this anterior cerebral artery, it runs on the medial surface of the brain, and the area of supply of this anterior cerebral artery is that it will supply the whole of the medial surface of the brain, except the occipital poles, and also the superomedial margin of the superolateral surface.
Okay.
Then coming to the this middle cerebral artery, this middle cerebral artery, it runs through the stem and the posterior root of lateral sulcus of the brain. Then it appears on the superolateral surface of the brain. Then it will supply most of the areas of superolateral surface except the occipital lobe and inferior part of the temporal lobe, and except inferior part of temporal lobe and the inferior surface of the brain. Except those areas, it will supply mostly the superolateral surface. Then this is about the anterior circulation, internal carotid branches.
Okay.
Now coming to the posterior circulation, which is from the vertebral artery. Vertebral artery, it is a branch from the first part of subclavian artery. Then it ascends in the neck through the foramina transversorium of the upper six cervical vertebra. Then it enters the cranial cavity through the foramen magnum. Then it runs, there are two arteries, right and left artery. They run over the surface of the medulla oblongata. Then at the lower border of the pons, both the arteries will meet with each other to form a basilar artery. Then this basilar artery, it will run over the surface of the pons, and it will divide into two right and left posterior cerebral artery. Coming to the branches of the vertebral artery, this vertebral artery will supply mainly the spinal cord, that it will give anterior and the posterior spinal arteries. Then it will give the medullary branches. Then it will supply the cerebellum. Few of the branches supplying the cerebellum is the posterior inferior cerebellar artery coming from the vertebral artery. Now coming to the basilar artery, it will give the pontine branches, which will supply the pons, and it will give the three cerebellar branches, that is the anterior cerebellar artery and superior cerebellar artery, which will supply the cerebellum. Then coming to the next artery, which is supplying the cerebrum, is the posterior cerebral artery. This posterior cerebral artery, it arches over the crus cerebri and enters into the medial surface of the cerebrum, and it mainly supply the occipital lobe of the cerebrum. That is mainly the visual area where visual area is located, and it will also supply the inferior surface of the cerebrum where our temporal lobes are located, and inferior part of the temporal lobe is supplied by the posterior cerebral artery.
Okay. There is a lot to remember, but as the discussion progresses, we will come to the clinical and applied aspects of and the importance of knowing the exact blood supply of brain. And just continuing with the same topic, I think it's also important to know about the circle of Willis and how the relevance of it in the whole circulation. Can you just explain on that also?
Okay, sir. This circle of Willis is a polygonal anastomosis which is located in the base of the brain at the interpeduncular fossa around the optic chiasma. Okay. So coming to the formation of circle of Willis, anteriorly it is formed by the anterior communicating artery. Then anterolaterally it is formed by an anterior cerebral artery. Then laterally it is formed by the internal carotid artery. Then posterolaterally it is formed by the posterior communicating, and posteriorly it is formed by the posterior cerebral artery. Then coming to the branches of this arterial circle of Willis, mainly it will supply the deep cortical area. It will give the following branches. One is the anteromedian branches, which will supply the anterior part of the hypothalamus. Then it will give the anterolateral branches. These anterolateral branches are important. These are called as striate arteries. So there is a medial and the lateral striate artery. This medial and lateral striate, they will mainly supply the internal capsule and the corpus striatum, and these striate artery are called as the artery of cerebral hemorrhage. Okay. Then there are the posterolateral arteries which will supply the our pituitary gland and the hypothalamus posterior part. Okay. Then there is a posteromedian arteries. Okay. This posteromedian artery will supply the pulvinar end of the thalamus and some part of the lentiform nucleus. Okay. So this is the different branches of the circle of Willis. Okay. And coming to the significance of circle of Willis is that it forms anastomosis between the branches of the this internal carotid artery and the vertebral artery. So these flow of blood, that is stream of blood which is present in these two arteries, they will come into communication at a one point that is called dead point in the posterior communicating artery. Okay. Posterior communicating artery, there is one dead point. They will come together, but there is no mixture of blood in the normal individual. That is a normal circumstances. But whenever there is a occlusion of any one of the branches, the collateral circulation begins, and the whatever the tissue is deprived of the blood supply, that will be supplied by this collateral circulation. Okay.
Right. I think that's the relevance of it, right? Thank you, Doctor. Moving to Radambika, Madam. Madam, can you describe us regarding the cerebral autoregulation?
Autoregulation of the blood flow in the brain is a very important thing, actually. And before that, we must know a little about the blood supply of the brain. About 750 ml per minute of blood is going to the brain. Okay, it is about 15% of our cardiac output. Normally, everybody knows cardiac output is 5 liters per minute. Right. So 750 ml. And when you see the distribution of this blood supply, it is more in the gray matter compared to the white matter. Okay. And any area, if you are doing an activity, the area representing that in the brain receives more perfusion. And when you see autoregulation means what it is. Autoregulation means for the wide range of systemic arterial pressure, the perfusion is maintained constant. Yes. The perfusion is not decompressed. So that is very important, because everyday activities, so many other things, there will be wide fluctuations in the systemic arterial blood pressure. So what happens here is, in the range of 65 to 140 millimeter Hg in the brain, that is the autoregulating BP level. So 65 to 140 millimeter Hg, the perfusion is maintained constant. Okay. Whenever there is increase in systemic arterial BP, what happens is the cerebral vessels undergo vasoconstriction. There is a sympathetic supply also, parasympathetic supply also. Not only that, other metabolites also act locally in the blood vessels. They adjust the caliber, PaCO2 will cause vasodilatation, decreased PO2 will cause vasodilatation. So many mechanisms are occurring in the brain to alter the caliber of the blood vessels and do the autoregulation methods. Mainly myogenic mechanism is also there, whereby the blood vessel itself can constrict or relax because some arterioles will have some smooth muscles. And this autoregulation is important because if the BP goes below the 65 millimeter Ag, the blood supply will be very much compromised. Very much compromised, and the person may become symptomatic. Same way, if the blood supply goes above 165, that time the perfusion will increase too much. The perfusion will increase too much, and it may cause breach to the blood-brain barrier. And so many neuronal problems may occur because of that.
Right. Okay, madam. So, madam, one more question. How does the brain utilize its fuel for its metabolism? So, if you can just quickly,
The main fuel for the brain is glucose.
Yes.
And the metabolism is aerobic metabolism. So, glucose is the main fuel, and this glucose, once it enters the brain through GLUT1 receptors, that doesn't require insulin. So, through that, it will enter the blood-brain barrier. It is present in the endothelial cells, which forms the barrier. So, once it enters, this glucose undergoes glycolysis and also oxidative phosphorylation to generate ATP. ATP provides the energy, and brain needs a lot of energy because a lot of neuronal connections are there, many mechanisms are undergoing there. So this energy, the main fuel, is provided by glucose. Only in extreme conditions like starvation, sometimes ketone bodies may be required. Otherwise, it is using glucose. That is why even for 10 minutes, if you don't get a blood supply, the person becomes, 10 seconds he becomes unconscious. In 5 or 6 minutes, he reaches a vegetative state if he recovers. And in 10 minutes, he will go into brain death, somewhat.
So thank you. I'll come back to you with next question. Before that, Shankar, can you classify CVA and how will you differentiate the various types of CVA from a history perspective?
Actually, CVA is a abrupt onset neurological deficit due to a vascular cause. That is the definition. So it can be due to ischemia or an hemorrhage. So it has different manifestation depending on the site affected. So patients can present with paralysis, sometimes sensory deficit, sometimes dizziness, diplopia, visual loss. So depending on the site, the manifestation or presentation varies. So as I already told, it can be due to ischemia or hemorrhage. So hemorrhage can be intracerebral hemorrhage, that is bleeding into the brain parenchyma. And secondly, it can also due to subarachnoid hemorrhage, that is bleeding into subarachnoid space, maybe due to rupture of a berry aneurysm. So each will be having different clinical manifestation. And ischemia, it can be due to either a thrombotic stroke, or due to an embolism. Thrombus may be due to an atherosclerosis with the superimposed thrombosis, and emboli can result from dislodging from a distal thrombus, maybe from a heart or an artery. So when you take the history, we can clearly differentiate between whether it is due to ischemia or hemorrhage by asking certain questions. Whenever we take a history, we should focus mainly on, we'll ask in detail everything, so we should focus mainly on time of onset of the deficit, the magnitude of the deficit at the time of onset, and its progression. If we address these three questions, we'll get somewhat idea. So first we discuss with the hemorrhage. In case of intracerebral hemorrhage patients, at the time of onset, sometimes patient may be having headache or vomiting. In other ischemic strokes, these symptoms might not be there. And in intracerebral hemorrhage patients, it can be either abrupt onset, or usually it will be a gradual onset and progress over few minutes to hours. Sometimes in some patients, it can be of abrupt onset and patient rapidly progress into coma. And in subarachnoid hemorrhage, most of the time patients present with a severe headache. Sometimes they will describe as the worst headache of his life. And on clinical examination, sometimes patient will be having neck stiffness. So that is the presentation of intracerebral hemorrhage and a subarachnoid hemorrhage. Coming to thrombotic stroke, the time of onset, usually thrombotic stroke occurs in the early morning time. It is said that early morning time is a prothrombotic state. So many hypotheses are there. I'm not going into that. Okay. So deficit will be minimal, and over few minutes or few hours or days, it will progress, evolve. That is called a stroke in evolution. Whereas in embolic stroke, the deficit will be maximum at the time of onset because the vessel is completely occluded. And one more thing, in the history, when you ask about past history, any similar complaints in the past, usually patients with the thrombotic stroke give a history of TIA, transient ischemic attack. So that means in future patient can develop a thrombotic stroke.
Now, since we have discussed regarding from the history how to identify the type of stroke, I think it's also important for us to identify the cues or clues from history to kind of localize the area of an ischemic stroke. If you can share some light on that, yeah.
So we know the basic anatomy of the brain. Actually, we have a cortex, a subcortical region, corona radiata, internal capsule. Then comes the brainstem, midbrain, pons, medulla, then spinal cord. Okay. So basically, for a case of hemiplegia, let me say, we can divide into three sides: hemispheric lesions, brainstem lesions, and spinal cord lesions. Okay. So in hemispheric lesions, it can be cortex, corona radiata, or an internal capsule. So if it is cortex, patients will be having sometimes seizure. Patient can have aphasia. Sometimes cortical sensation may be lost. That is 2-point discrimination, tactile localization, stereognosis. But the primary modalities of sensation will be preserved. Okay, and the weakness will be minimal weakness only. Either one upper limb will be affected because the fibers are diffusely spaced. So either for an upper limb with minimal weakness or a lower limb with minimal weakness. So that will be the presence of a cortical stroke. So features of cortical stroke will be aphasia. Okay, primary modalities will be intact, but there will be loss of cortical sensation and minimal weakness. When it comes to corona radiata, weakness will be much more pronounced than the cortical stroke. So patient can have either upper limb or both weakness, upper limb or lower weakness with asymmetry. Either one upper limb weakness will be more or a lower limb weakness will be more. When coming to internal capsule, the fibers are closely spaced. So we usually say dense hemiplegia and all. That is equal weakness of the upper limb and lower limb. But usually it is very difficult to elicit that from the history because patient may not be subjective. It can vary subjectively. So they may not be tell if the weakness is equal in both upper or lower limbs. So by examination, we can, by motor system examination, we can assess that, okay, it is dense hemiplegia, it is equally affected. Okay, then coming to brainstem, midbrain, pons, medulla. So we have corticospinal tract. Along with that, we have corticobulbar tracts also. So UMN and LMN lesions are there. So in the brainstem, we usually have the nuclei. 3, 4, 5. 5 will be having in pons, medulla up to spinal cord. So usually midbrain have 3, 4, 5. Then pons will be having 5, 6, 7, 8. And 9, 10, 11, 12 cranial nuclei will be in the medulla. Okay. So in brainstem lesions, we'll get crossed hemiplegia. Okay. That means ipsilateral involvement of the cranial nerve. That is, nucleus is affected and the spinal cranial nerve is affected. That is the LMN part. So ipsilateral cranial nerve lesion with the contralateral hemiplegia. So that is a feature of brainstem stroke. In spinal cord, above C5, if there is hemisection, say in Brown-Sequard syndrome, you can have again a hemiplegia above C5 level. So that is the anatomical distribution, and we can localize the stroke accordingly. And depending on other sites also, say if it is in the lateral medulla, the cortical spinal tract will not be affected. Okay. So patient will be having other symptoms. 5, 9, 10, 11 cranial nerves will be involved. So patient will be having dysphagia. And spinothalamic tract will be affected. So pain and temperature loss on the opposite side. And ipsilateral Horner syndrome. So I still remember one of my teachers saying, if you spot a patient, walking patient with a Ryle's tube in a neurology ward, you can think about lateral medullary syndrome. So I
think we will discuss this topic in detail again and to Dr. Rajashekhar. So, what should be an ideal investigation of choice, initial investigation of choice in a patient with suspected stroke?
For the time being, actually, in India, in most of the centers, what we have seen is CT is the first line of investigation of choice. This is because of three reasons mainly. One is the widespread availability of the CT. Number two is that most of the patient coming with early acute stroke might be in the window period. So, in order to save the window period, we have to do the scan very rapidly. So CT scan can be done very rapidly. So that is another second point. And the third point is that any resident can diagnose as hemorrhage in CT. Even in medicine department can diagnose that. And diagnosing intracranial hemorrhage in stroke is very important from their treatment point of view. Then, having said that, the CT MRI is definitely a investigation with higher sensitivity, which can detect infarcts early, the stages of infarct, as well as the etiology of the infarcts. But in the coming days, when the MRI become more widely available, I think MRI can be the first line of investigation.
So basically, once the patient comes in, we take a CT, and if the bleed is not there, usually we move ahead with the thrombolysis kind of pathway. So, but as you told, MRI remains kind of a better tool with a greater sensitivity. So, can you just quickly elaborate on the MRI sequences and what exactly is we are looking in stroke?
MRI sequences are mainly in stroke centers. They are mainly they programmed in such a way that we will reduce the scan time maximum as much as possible. Right. So for that, mainly four minimum sequences are required, which include the FLAIR images, or otherwise called the fluid inversion recovery sequences. Right. Second is the DW sequence or diffusion weighted imaging. Mm-hmm. Third is the ADC, apparent diffusion coefficient sequences, and the GRE sequences, which is used to find out intracranial bleed. So these are the common minimum sequences that are needed to diagnose a stroke actually. And if time allows, we can do plain TOF MR angio also, where we do not have to inject contrast, but we will be able to see all the major vessels.
So stroke will be more visible in definitely an MR kind of sequence, and the TOF will kind of help us to identify the blood supply. Yes, where definitely. Exactly is the problem, definitely. Right? Okay. Moving to Lalitha madam. Madam, it's very important for any medical student to understand the concept of both motor and sensory homunculus. So, and it has great clinical implications also. If you can elaborate on that.
It is a map actually which represents the various body parts in the hemispheres. Mm-hmm. And actually it is represented in an upside down fashion. Right. That is, the head part is down and the legs are up, and it is in the contralateral hemisphere.
Okay.
The body representation is such that if suppose a person is getting a lesion on the left side, the right sided muscles are affected. Right. So there are two maps actually. There is a sensory homunculus and there is a motor homunculus. In both of these, there is a point-to-point representation. That is, each part of the body, it is having a representation there in the brain. Okay. And sensory homunculus, if you take, it is situated in the post-central gyrus, in the parietal lobe. And here, the areas which are having a increased receptor density, like your lips, your hands, all have a very big representation there. When you see the picture of the sensory homunculus, you'll find that there is a big area for the face, the lips, the fingers and other things, whereas the trunk, body, all are very small, and you find that the limbs are more on the top and towards the medial side. Right. Whereas when you see the motor homunculus, it is in the precentral gyrus. The precentral gyrus, and here the areas where you have fine skilled movements, like we use our hands a lot. So hand has a very big representation, especially the thumb. Thumb itself is having a very big representation in the motor homunculus. So all the skilled movements, which are articulation, your speech, your areas for the larynx, the lips, that jaw, everything, there is a big representation there compared to the lower limbs and other things. So, and one thing what we see in the sensory and motor homunculus is our brain is very malleable. There's something called synaptic plasticity. Because if you don't use a part for a long time, there is something called the neurons, the synapses are modified in the brain. So that if suppose the person has an amputation of the limb, the area that represents the limb earlier is replaced by the other parts which are adjacent to it.
Okay.
So that is why we see some people who are blind, they have a lot of, they are able to hear sounds very well and do that is called synaptic plasticity. That is one important phenomenon we see in the brain. The adaptability of the brain and the increase in the neuronal circuits in parts which we are using frequently.
Right.
And actually the motor areas, when we say it is area 4, motor area 4, and we have a premotor area which is for planning and programming the movements, and there is a supplementary motor area, and these plan the motor movements along with the cerebellum and basal ganglia. And sensory, if you are taking the postcentral gyrus, we also call it the Brodmann's area 312, Brodmann's area, and that is receiving the impulses mainly from the thalamus, through the thalamus, from the different parts of the body.
Okay, ma'am. To Dr. Supriya. Ma'am, can you just describe the motor, sensory and speech function areas in the cortex?
Okay, sir. So motor areas, these are mainly located in the frontal lobe. First coming to the primary motor area, it is located in the precentral gyrus, and premotor area is located just in front of the primary motor area, which will include the posterior part of the superior middle and the inferior frontal gyrus. That is the premotor area. Then there is a frontal eye field, that is area number 8, which is located in the posterior part of the middle frontal gyrus. Then rest of the frontal lobe, that is called as the prefrontal area. Rest of the frontal, apart from these two. Then coming to the sensory areas, functional areas, these are mainly located behind the central sulcus. First coming to the primary sensory area, that is located area number 312, that is in the post-central gyrus. Next is the sensory association area, which is located in the superior parietal lobule, area number 5 and 7. And these primary motor area and the primary sensory area, they also extend into the medial surface of the brain, that is in the paracentral lobule, that is mainly for the lower limb and the representation of the perineum. So these are the sensory area. Now coming to the speech area. Speech area of two, one is the motor speech and the sensory speech area. That motor speech area, it is called as the Broca's area, which is located in the inferior the inferior frontal gyrus, that is surrounding the pars orbitalis and the pars opercularis. That is the motor speech area. If there is a damage, then there is a motor, we call it as a motor agnosia. Then coming to the sensory speech area. Sensory speech area, it is located in the inferior parietal lobule, that is surrounding the pars triangularis and angular gyrus and the supramarginal gyrus, that is the area of location. And there is a Wernicke's area, which is the area number 22, which is located in the superior temporal gyrus on the superolateral surface. That is the Wernicke's area. If there is damage to that area, there is a word deafness. Now coming to the two more area, that is visual area and the auditory area. So visual area is having two parts. One is the primary visual area and the secondary visual area or visual association area. Primary visual area, it is located in the calcarine sulcus, that is in the occipital lobe, that is lip and the lateral wall of the calcarine sulcus. Then surrounding this primary visual area, we have the secondary visual area. Now coming to that auditory area, this auditory area is the primary auditory area, which is located in the superior part of the superior temporal gyrus. That is the primary auditory area. And this Wernicke's area, it is also known as the auditory association area or the secondary auditory area. So those are the main areas.
One more question to you, ma'am. Can you outline the main cranial nerve nuclei and its location in the brainstem?
This brainstem consists of the medulla, pons, and the midbrain. Coming to the medulla oblongata, so in medulla we are going to study the three sections mainly for the UGs. First section is at the motor decussation.
Right.
That is the pyramidal decussation. In that we have a spinal nucleus of trigeminal nerve.
Okay.
This spinal nucleus of trigeminal nerve, mainly it will carry the pain and temperature sensation from the ipsilateral trigeminal nuclei.
Right.
Now second section is at the secondary, that is the sensory decussation. At the sensory decussation we again have this spinal nucleus of trigeminal nerve. Along with that one we are having a dorsal nucleus of vagus. Okay, dorsal nucleus of vagus, it will be carrying a preganglionic parasympathetic fibers which will supply our heart and smooth muscles and glands of the GIT and the respiratory tract. Right. Then coming to the one more section at the medulla, section at the mid-olivary level.
Okay.
And in the section of the sensory decussation, we have one more nucleus, that is the hypoglossal nucleus. This hypoglossal nucleus which will supply all the muscles of the tongue except the palatoglossus. Then section at the mid-olivary level, we are having that inferior salivatory nucleus. Inferior salivatory nucleus, it will supply the this parotid gland, preganglionic secretomotor fibers to the parotid gland. So these are the nuclei which are located in the medulla.
Okay.
Now coming to the pons, in the pons we are having a two section. One is at the section at facial colliculus, above the facial colliculus. Section at the level of facial colliculus, we are having a motor nucleus of facial nerve,
Okay.
which will supply the muscles derived from the second branchial arch. Then we have the just posterolateral to this facial nucleus, we have the abducent nucleus, which will supply the lateral rectus muscle.
Okay.
Then we are having this superior salivatory nucleus which will supply the submandibular and the sublingual preganglionic secretomotor fibers are supplied by this superior salivatory nucleus. Then we are having a vestibular group of nucleus and the cochlear group of nucleus in the pons.
Okay.
Next, coming to the next section above the facial colliculus, here we are having a trigeminal nuclear complex. One nucleus of trigeminal nerve is a motor nucleus of trigeminal nerve which will supply the muscles of first branchial arch. Then we are having a principal sensory nucleus of trigeminal nerve which will carry the touch and pressure sensation from the ipsilateral trigeminal nucleus.
Okay.
Then we have a mesencephalic nucleus of trigeminal nerve which is carrying a proprioceptive sensation from the muscles of face and mastication. So these are the nuclei in the upper pons. Now coming to the midbrain, we are having a two section. One is at the superior colliculus and the inferior colliculus. Okay. In the inferior colliculus, we are having that is trochlear nucleus, that is the fourth cranial nerve nucleus which will be supplying a superior oblique muscle. Then section at the level of superior colliculus, we are having a oculomotor nuclear complex which will supply all the extraocular muscles except superior oblique and lateral rectus, and along with that we are having a Edinger Westphal nucleus which is supplying a preganglionic parasympathetic fibers to the ciliaris and sphincter pupillae. Then pretectal nucleus. So these are the different nuclei.
Thank you, ma'am. Move on to Dr. Shankar. Shankar, can you just quickly tell us something about the fast assessment in stroke and also the kind of the concept of window period in the management of stroke? Yeah.
Fast assessment means it is introduced to recognize a stroke early. Okay, so fast means F for face, A for arms, S for speech, and T for time. So face, observe whether the patient is having any drooping of any one side of the face, or you can ask the patient to smile. Okay. Then A for arms, is there any weakness of the upper limbs? You can ask the patient to lift the arms. You can see any weakness, anything like that. Then S for slurring of speech, you can talk to the patients. Okay, you can assess by that. And time, if any of these features is there, it is time to call the emergency services. So the problem with FAST is that it can usually pick up most of the strokes involved with the internal carotid artery, that is anterior circulation. So some of the posterior circulation, the symptoms may be vertigo, dysarthria, things like that. So most of the time the FAST was not able to pick up these strokes. So there is a new assessment score, that BFAST. Okay, so BEFAST. So B means balance, to assess the gait of the patient, or you can ask the patient to lift the lower limbs. You can assess is there any weakness. E means eye, any visual loss, diplopia, things like that. So that is the concept of FAST and BFAST. So window period means the time of onset of stroke to time of initiation of the treatment. Okay, it is very important because it is considered at least you have to start treatment within less than 3 hours. Okay, so any patient, like sir said, we will immediately do a CT scan. If a bleed is ruled out, we can start thrombolysis. But various studies has shown that, I think one article published in 2008 in EJM. So they have studied patients coming to out of this window period. So they studied patients coming between 3 hours and 4.5 hours, 4.5 hours. So in that study, it was observed that people coming in that period also, if we initiate the treatment, there is better outcome. So we can use the MRI also. So in MRI, sir already told diffusion weighted image and perfusion weighted images. So diffusion weighted images usually give us an idea about the infarcted tissue. That is, the tissue is already damaged. So perfusion weighted images will give you an idea of the blood supply to the surrounding area. That is the ischemic penumbra. So if there is a significant mismatch between this PWI, perfusion weighted image, and diffusion weighted image, actually we can start the treatment even if the patient is coming out of the window period, that is more than 3 hours. So if patients meet such criteria, extended window period, maybe up to 4.5 to 6 hours, we can start the treatment.
To Dr. Ajay sir, can you explain regarding the role of neck vessel imaging and angiogram, not only in acute stroke but also in the workup of TIA?
Basically, on the basis of the cause of the stroke, we can divide the stroke into ischemic stroke and thrombotic stroke, as he said earlier. Now, the importance of neck vessel or neck vessel angio mainly comes when we consider the embolic stroke, because in brain most of the source of the embolus will be from either from the carotid artery or from the arch of the aorta. So that's why neck vessel angio becomes important. Now the important basic diagnostic modality for neck vessel angio starts from neck vessel Doppler. So neck vessel Doppler mainly it is a real time study. We can keep the probe directly over the neck and can real time see the intimal thickness. We can see the plaques. We can characterize it whether it is calcific plaque, non-calcific plaque. Then we can also screen the carotid lumen stenosis. So this is but only a screening sequence, but we have to definitely do the next step, imaging. This is a non-invasive screening sequence. Next imaging will be the CT angio. So always CT angio is the principal imaging in neck vessel angio. This is because it has got high temporal resolution, and whatever measurement you take in CT angio will be accurate because of the high temporal resolution. So it will be useful for endovascular study, for measurements of the coils, measurements of stents can be made based on that. Then another thing is that beyond that, if there's another alternative investigation will be MR angio, where in some cases there will be contraindication for radiation, like in small young adults. Then there will be contrast reaction, then for iodine contrast, then contrast-induced nephropathy, then in case of moderate to severe renal failure. In such cases, we can use MR angio as an alternative. But always the gold standard for angio will be a digital subtraction angiography. That is an invasive study where we intraarterially get into the neck vessels through a transfemoral approach. and index directly contrast into these vessels and take a fluoroscopy, video fluoroscopy.
Thank you. And now to Dr. Shankar, can you just outline the medical management of acute stroke? And also probably a quick word about the preventive aspects also.
So acute stroke, like we discussed, early to start the treatment. So it is very important so that the patient has to be taken to a stroke center. So in our country, in lot of peripheries, the stroke center might not be available. So patient will be taken to a primary care center or a secondary care center. So anyway, CT facility might be there. So if we have taken a CT and ruled out a hemorrhage or a bleed, we can think about thrombolysis. Okay. So any patient who is older than 18 years of age and a diagnosis of ischemic stroke is made, and that patient who doesn't have any coagulopathies, who had any previous history of intracranial hemorrhage or any history of intracranial space occupying lesion or a prothrombin time of more than 1.7, platelet less than 1 lakh. So many exclusion criteria are there. So if a patient is fit to undergo a thrombolysis, we can start with IV thrombolysis. So we can use alteplase or recombinant tissue plasminogen activator. So the dose will be 0.9 mg per kg, and you can give maximum up to 90 milligram. So the 10% of it should be given as bolus immediately, and 90% over the 1 hour. And a rest maintenance of airway, breathing, circulation, everything has to be maintained. And one more important thing is that if the BP is more than 185 or 110, so patient is not fit for thrombolysis. So we have to be careful.
The BP.
Yes, sir.
And during the thrombolytic phase also probably we need to control.
Yes, sir. Yes.
And regarding the secondary aspirin and statins?
Actually, if the patient was on heparin or things like that, within 48 hours, we should not thrombolyze. Or we can at least give aspirin 325 milligram loading dose, a clopidogrel 75 milligram, and statins we can give immediately.
So that's with the medical management. From an interventional point of view, interventional radiological point of view, what are the newer things in stroke management?
Interventional point of view, I would like to explain it in 3 clinical scenarios. One is a patient coming with a ischemic stroke, having acute occlusion of any of the large vessels like ICA, MCA, or ACA. Like such situations, if the patient is in window period, we first calculate if needed, the clinical evaluation is there, like aspect score is there, then diffuse method is there, 2-3 criteria are there. So that we will consider. Then again, if radiologically, if we needed we will take the diffusion perfusion mismatch, and if it is significant, then we will go ahead with the intra-arterial thrombolysis. So in that we will transarterially enter into the vessel with a diagnostic catheter. Then after reaching that, if it is a mild narrowing and all, we can try only intra-arterial thrombolysis with alteplase. But if it is a segmental occlusion like thing, then probably we have to do mechanical thrombectomy. And mechanical thrombectomy can be always combined with followed by intra-arterial thrombolysis to keep the lumen of the vessel patent. Then next clinical scenario is a hemorrhagic stroke where there is a bleed in the brain. In that case, a CT angio will be done, and we have to find out what is the cause of bleed, whether it is due to aneurysms or if it is due to AVMs, or we have to find out what is the cause. Then in such cases, we will do, depending upon the results of the CT angio, we will be planning for coiling if it is aneurysm, and if AVM, we can plan for embolization. In such cases, again, we have to do DSA. Intra-arterially, we have to do DSA. In DSA, we have to plan the coils which has to be used for occluding the aneurysms. So with the help of diagnostic catheters, we can reach the neck of the aneurysms. Into the neck of aneurysms, we can put coils, previously decided coils we can deploy. And these coils will thrombose of the lumen of the aneurysm. And in some cases, we have to protect the parent vessel also. Sometimes the coil will go into the parent vessel. In such cases, we can use braided stents to prevent the migration of the aneurysm also. Then third scenario I want to tell is carotid artery stenosis, where carotid artery stenosis can be a major source of embolic embolus to the brain. In such cases, we can do intraarterially do DSA. Then we can cross the narrowing with diagnostic catheters and do angioplasty with balloon. And in order to prevent embolus migrating to the brain, even we can do stenting and keep the lumen patent.
Thank you. To Madam. Madam, can you tell briefly about the physiology of speech? That is something which we didn't discuss much on. Yeah.
Speech actually is an expression of our thoughts and ideas. There are two types of speech actually. There is one what is called spoken speech. The other one is written, verbal speech and written speech. So actually, as Dr. Supriya told, the areas for speech are the Wernicke's area and the Broca's area. So when we are hearing a word or when we are hearing a sound, the impulse is going to the primary auditory area. And from there it goes to the Wernicke's area. And in the Wernicke's area, which is area 22, what happens is it comprehends the message and gets the message of what the word is. And then from there, the impulse has to be sent through the arcuate fasciculus to the Broca's area. The Broca's area is the area which will find the exact words what you need to reply to the question you are getting. And it is the motor speech area, the Broca's area. This is what happens when you hear the word or when you are getting an answer. And actually this has to go to the motor area, the pyramidal tract, then only executes the movement by articulation of the larynx, lips, tongue. All the movement is regulated by the motor area. So many things are taking place before you express a word. And dysarthria can be of two types. Either it can be due to a problem in the motor area that the person is not able to get the exact words. As she told, if there is a lesion in the motor area in aphasia, they will not be able to express what they want. So there may be a difficulty in articulation. Or sometimes it's a pure pyramidal tract lesion in the internal capsule or something where these areas are not involved. The dysarthria may be just due to the difficulty in the articulation of the various muscles. Okay. And about written speech, suppose you are writing a word or something, that also goes to the Wernicke's area. But here, first it goes to the primary visual area in the occipital cortex, area 17 in the occipital cortex, and then it goes to the angular gyrus. Angular gyrus only understands the meaning of these written words, and then it goes to the Wernicke's area, which comprehends the thing, and then Broca's area, when after it goes to the arcuate fasciculus, that's a set of neuronal fibers connecting the Wernicke's and the Broca's area. So here when it goes there, here the words, exact words are found, and actually again the motor area is the one which is executing the movements with the hands. Right. What you have to write, what you have to do, everything. That is why if there is a lesion in the Wernicke's area, it is called fluent aphasia. The patient is not at all comprehending what you are telling, right, but he is trying to talk something else. Mm-hmm. He is giving a lot of words. That is why it is fluent aphasia. Right. And sometimes even he coins new words, neologism. It is called neologism, new word, set of words. Mm-hmm. Whereas Broca's area means the words are very scanty and there are no conjunctions or prepositions in what he is telling. So actually the words, it is called telegraphic language, okay, like split words. That is what happens when there is a lesion in the Broca's area. And written speech, fully if it is to be executed, there is one more area called Exner's area. Okay. So after reaching the Exner's area only, right, then it goes to the motor area, and the written thing is completely understood as well as written. Right. So that is what, and sometimes there will be lesions affecting both these areas and other things. A lot of combinations can occur.
Okay, thank you, ma'am. Last question to Dr. Shankar. There is this thing called as young stroke, right? The workup is slightly different from when stroke comes in an elderly patient. So can you just tell something about the workup in young stroke and also a quick overview of the complications of stroke? Yeah.
So, young stroke can be due to multiple causes. Maybe due to a cardiac causes. Say patient, a known case of rheumatic heart disease, patient on any prosthetic devices, vegetations can be formed, emboli can be there. Patients with atrial myxoma, such patients can have AF, thrombus formation, emboli can be dislodged. So these are certain cardiac causes. So patients with any congenital heart disease, rheumatic heart disease, myocarditis, myocardial infection, AF, atrial myxoma. So these are the cardiac causes. So next set will be hematological causes. Patients with sickle cell disease and any patient with who has a prothrombotic state. Okay, say a patient with mutation, a protein C, protein S deficiency, factor V Leiden deficiency, mutation. Okay, in such patient, elevated homocysteine levels, polycythemia. So in such patient, there is high chance. So it is a prothrombotic state. Thrombus can be formed. Then again, stroke. Emboli can be dislodged, things like that, or thrombus in the intracranial vessels itself. And sometimes due to other prothrombotic situation will be ladies, pregnancy, ladies using estrogen-containing contraceptive pills. And next will be a vascular cause. Maybe patient who is having a systemic hypertension or an aortic dissection or a moya disease. That means stenosis of the internal carotid artery. And any vasculitis, giant cell arteritis, Takayasu, Kawasaki, polyarteritis nodosa, or post-infectious vasculitis, secondary to HIV, varicella, TB, syphilis, any fungal infection. So these are situations where patient is in a prothrombotic state. And sometimes individuals who are using cocaine, methamphetamine, so they are at high risk of developing a stroke. So these are the basic causes of young stroke. So the evaluation will be taking a proper history. First, taking a proper history. What is the symptom? Any cardiac causes, if we take any history of cardiac diseases from the childhood, most of them will be diagnosed to have rheumatic heart disease or any known case of cardiac illness might be there in them. So we can evaluate taking an ECG, doing an echo. If we are suspecting infective endocarditis, we can send blood cultures according to that infective endocarditis panel, and doing a transesophageal echo, we can evaluate cardiac causes. And again, patients with the vascular causes, it can be aortic dissection. Typical presentation will be central chest pain radiating to back. We have to suspect such things. And symptoms of vasculitis. Any patient, young individuals with symptoms of vasculitis, we have to think about. And detail young lady. I think recently in newspapers where the one girl, a 21-year-old girl was died due to stroke because that lady was taking estrogen-containing contraceptive pills. So detailed personal history we have to take. So again, next, inflammatory, any infections. Patient had any varicella, symptoms of meningitis, bacterial meningitis patient had, any varicella zoster infection, any HIV. Okay, all these situations we can take proper history, general examination, and we will get a clue what all investigations to be done. So that way, likewise, we can evaluate for young stroke. So the stroke complication will be usually a long term. Mostly the medical complications will be pressure sores. Patient will be bedbound for so long, development of pressure sores. So we have to be give care every hourly changes, body position changes, things like that. And post-stroke seizures. Okay, some of the patient may develop post-stroke seizures, and sometimes patient will be having contractures. Actually, they have to be under physiotherapy, okay, proper physiotherapy guidance, because if there is disuse, contractures will be formed. Okay, then psychosocial, that is, patients will be having depression. So we have to, so we can treat it with SSRIs. Sometimes we have to give counseling even to the caretakers. Okay, long term. That we have to counsel them, explain to them. Okay, so with such situations we can manage.
Now, with that, we have come to the end of all pre-planned questions. Just one final round. Can you just based upon this topic, can you just give some important questions which you should be prepared for from anatomy in this topic? Yeah.
Okay. So blood supply of brain itself is a long essay.
Okay.
And circle of Willis, it is a short essay question. And functional areas of the brain, that is also long essay question.
Right. So we covered all three. Good. Madam?
In physiology, we ask the special features of the cerebral circulation.
Okay.
So all the special features I told, no, like gray matter gets more blood, like that. One important, another one point is perfusion is dependent on gravity also. Cerebral blood flow is dependent. That also they have to add to the answer.
Okay.
And the autoregulation of cerebral blood flow, that is another one important question.
Okay.
And homunculus, sensory homunculus, motor homunculus,
We
both
covered.
are important.
Right.
Physiology of speech, and in physiology of speech, actually, the sound during exhalation only, it comes out through the vocal cords, and because of the vibration of the vocal cords, only phonation and the sound comes. I just told about the areas and the thing. So in physiology of speech, they have to write this also, how actually the speech mechanism comes.
Okay.
And then aphasias.
Okay.
We ask aphasias, both sensory as well as motor aphasias, as short note questions.
Okay. Thank you, ma'am. To Shankar?
Two aspects actually. An exam point of view, we have to take a proper history. From the history itself, what type of stroke it is. Okay, the cause, is it ischemic hemorrhagic, and you can localize the stroke. So what is UMN lesion, what is LMN lesions, how to examine motor system, how to examine sensory system. That eventually all will be learning in the bedside clinics. And most important thing is in the practical life. So the fast. So anytime being a medical professional, so everybody will be looking up to you. So think we have to at least identify a stroke immediately. So just see the fast, be fast. That's it.
Okay. Thank you all for this very engaging discussion, and I'm sure all students will benefit from it. Thank you.